4, 3.
Hi, and welcome to today's presentation on pediatric asthma. My name is Wes Stubblefield, and I'm one of the medical officers at ADPH. Some of you may have met me before, others may have not, but as background, I was a general private practice pediatrician for over 14 years before moving into the ADPH world. Through that time, I have extensive experience with all age groups from premature infants all the way up to young adults, and especially with asthma, as it's such a common disease in Alabama. So today, we're not going to get very technical, but I feel like it's important, since we're now looking into this program for our remote patient monitoring program, that you should have some basic understanding of pediatric asthma. For some of you, this will be a refresher. For some of you, this may be new information. For some of you, this may be redundant information. But I think we can all learn something as the treatment, the diagnosis, and the medications for asthma have changed over time. So over the next 30 to 45 minutes, we'll go through a little bit about how asthma is diagnosed, treated, and monitored in the pediatric age groups. So to get started, I wanted everyone to know that I have, of course, no financial relationships. If I use a brand name in this presentation, that's simply just for identification purposes. I do not have a brand preference, and the guidelines do not state brand preferences. There are age-specific preferences, but that has to do with the FDA licensure and has nothing to do with the brand. So again, no brand specificity, just thinking about what medications are out there, and so that when you are in a patient's home or you're talking to a patient, you'll know what medications they're on. So let's talk a little bit about asthma itself. So I think what's most important to remember about asthma is that asthma is a chronic inflammatory disease of the lungs. You can think of other chronic inflammatory diseases, diseases where someone might be on an anti-inflammatory medication, let's say arthritis. Asthma is chronic, meaning that it happens again and again. Children, especially very young children, may have symptoms that look like asthma very early in life, but not go on to develop asthma because it's just not something that becomes chronic. Once it becomes chronic, then it is asthma, and all asthma is asthma. There's different levels of asthma, so you can think about having a little bit of asthma, meaning that maybe you just have an occasional flare-up, and then you can have people that have very, very severe asthma to the point where they have difficulty functioning in their life. So it's a spectrum of disease. That's why we have a spectrum of medications. So asthma causes inflammation. The airways are more set up for inflammation. And the things that inflame the airways, and we'll talk about those in a minute, cause two things primarily. One is it causes mucus production. So anytime your body is inflamed, it sends its inflammatory cells and causes mucus. That's the same thing if you have a cold, but imagine that down in your lungs, down in the tubules. The other thing it does is that some of the airways in your lungs, some of the larger airways, or the medium-sized airways, are surrounded by a layer of smooth muscle. And smooth muscle is found throughout your body, but in this particular case, the smooth muscle constricts in your lungs and causes what's called air trapping. So you get air trapped in your chest that you can't get out. So when you're trying to breathe out, because the airways are constricted, you can't exhale air from your lungs. So this is an out issue. So if you've heard people wheeze, they're breathing out and they have to force air from their lungs. They have to use their muscles to do that. That's an obstructive process. So that's something obstructing the air coming out. There's also you can talk about an in problem. That's completely different. If someone has trouble getting air in, that usually is more up in the upper airway. Something like maybe a foreign body, or people have heard of the word stridor. Those are not asthma. Those are very, very different. So in versus out. I think that's important to remember. So again, this is an air out problem. If you take an x-ray of children's lungs when they have asthma, especially when they're flared, their lungs look completely full of air, just big and open and full of air. So this is something to think about when you're taking a look at children with asthma. And this is a representation on the screen of what we're seeing with that smooth muscle and the mucus. So why do people have asthma? Well, one of the biggest risk factors for asthma is family history. It has been shown that it is many times more likely in people who have a family history of asthma. But remember, asthma is only one of the three we call the triad, and that includes both seasonal allergies, or being predisposed to seasonal allergies. So some people are more predisposed than others. And also the disease eczema, which is also a chronic condition, but infects the skin. But people who have allergies and eczema are also prone to have asthma, and the same is true the other direction. So family history plays a very large part of this. And we see allergies as number 2. And we'll talk about later, but control of seasonal allergies can be very helpful in controlling chronic asthma. So if people have asthma, especially asthma that's very seasonal, they may need to be on other allergy medications starting early, making sure that they don't have those flare-ups, making sure that their body doesn't see that inflammation. One very important cause and also contributor to asthma are viral respiratory infections. It's been shown many times that children, if they get RSV early in life, are more prone to have asthma. And there may be something that RSV maybe causes asthma. It may unmask the underlying tendency to asthma, but there's definitely a correlation between those two conditions. So asthma and RSV are tightly related. But children also get colds, and they get colds very frequently in the first few years of life, especially after those maternal antibodies have worn off, starting around 6 months of age. And especially if they're exposed to other children, such as maybe siblings that are in daycare, or they have children, they're around other children in daycares. This is very important. And so having a cold, if you have asthma, can turn into a very serious condition if you're not well controlled. But also colds may actually lead to asthma, and many times in younger children, that's where we see the first presentations of asthma, are that they do this recurrently with colds, and then sometimes they start doing it without colds. So recurrent wheezing associated with viral respiratory infections is an important risk factor. We know that cigarette smoke or smoking from any exhaled smoke from other devices. So we think about electronic cigarettes or anything in that the electronic nicotine delivery systems, vapes, whatever you call it, the things that are exhaled from those devices has particulate matter, and it actually can irritate the lung lining. So cigarette smoke is a chemical irritant to the lungs. It is very, very difficult to control children's asthma, especially with more severe asthma, when they're exposed to cigarette smoke. And this is any cigarette smoke. This is not just people who smoke outside the home. People will say that they smoke outside the home, but many times that you will see them, and if you're a non-smoker, you smell them immediately when they come into the office. So it's very difficult to rid yourself and your clothing and your car and your household items, especially if you smoke in the home or even if you smoke in a different room. It's very difficult to eliminate that completely. So very important risk factor. Air pollution is an interesting topic. There was recently a study where they associated living, not necessarily consuming fast food, but living close to a fast food establishment may have contributory risks for asthma, thinking that cooking makes that small particulate matter, that 2.5 micron size that we talked so much about recently when we had the wildfires in Canada, that particulate matter in the air may actually be a contributing factor to developing asthma. So we think about air pollution. We also know that children who live in very dense urban settings are more likely to have underlying asthma than children who don't. And that may again go back to air pollution for many causes. And then a final one is obesity. We know that children who suffer with obesity, then they are also more at risk for having asthma. So you can see there's a lot of different things, but you think about asthma like you think of a lot of other diseases. Asthma there's an underlying predisposition, probably a genetic predisposition. There are other environmental factors that happen, some more than others. And then once we move beyond that, then we develop this cycle of chronic inflammation leading to the airway constriction, and then we have to use these medications to treat. So that is asthma. Asthma is asthma, just remember. So let's think about some basic demographics about who gets asthma. First, we think about sex and age. So children, it's more often males, and in adults, it's more often females. But the question I get a lot is, how young can you diagnose asthma? You can diagnose asthma very, very young. People may have heard you can't diagnose asthma before 2. I don't think that's true. I think we see infants that have asthma, and it's a clinical picture. So you've got parents who have severe asthma. The children had very terrible eczema, potentially even food allergies, and then they start getting viral respiratory infections, and they start wheezing with every cold. And wheezing is a term that we use when we think about that air getting out, that wheeze, that noise you hear when you're trying to breathe air through those small airways. It makes a noise like a whistle. And so wheezing so in that situation, we can diagnose children younger than 2. So children can be diagnosed young. Again, they usually don't start getting those recurrent respiratory infections until they're 6 months or so. And then especially, like I said, for those other risk factors, other children, daycare attendants. It's definitely those that identify as black, as much more so than white. It's 43% higher in those that identify as black. We also know that it's particularly lower in Hispanic and Asian, although that's somewhat misleading because not every person in every race group is the same person. There are people among different race groups that comprise Hispanic ethnicity that may have much higher or much lower predispositions. So these are generalized numbers, but just for our purposes, this gives you some general idea. So we think about family income. That we think that it's definitely higher among those with a family income below the poverty threshold, and that may again be very difficult to tease exactly what's going on there. Obviously, just having less money doesn't make someone more predisposed to asthma, but it could have a lot to do with living conditions, and we talked some about that before. Health insurance coverage, again, that goes along with family income, so we know that people, especially in adults, that rates are higher among those who have insurance qualified as Medicaid insurance. In the current child-adult asthma by state, it just really depends. So in Alabama, it's about 8%, but it can be all over the place. But asthma, that's pretty consistently, you can think of asthma as around somewhere around 10% of the population. So similar to what we see with ADHD, for example, are very similar numbers. So very common in our state, very common in our children. So we've talked a little bit about what happens in the airways. So what do children do when their symptoms flare? So what do? They cough. Cough is very much a symptom of asthma. So much so that in children, they may do nothing but cough. They may not wheeze. They may just cough. That is one of the presenting signs of asthma. It may be a nighttime cough, a persistent nighttime cough. That can be asthma with no other symptoms. But typically we see wheezing. We see that breathing out, that forcing that air out through those constricted airways, having trouble exchanging the gas, you having to use those extra muscles in your chest and in your stomach and bobbing your head because you can't get that air out. And it can be very scary for parents, but also for the children. And we talk about shortness of breath. One of the signs that can be associated with that is inability to speak more than a few words. So if you have a child who is coming into, say, an acute care setting, an emergency room or a doctor's office or anywhere, that child may be unable to speak more than a few words at a time. They may be unable to say very few letters of the ABCs because they just can't. They have to increase because they can't get their air out. The only way they can exchange air in their lungs in the outside is to breathe faster. So they breathe faster and faster, and that makes their breathing time shorter and shorter. We talked about wheezing. Another big one is exercise intolerance. So children who have asthma, many times you'll hear people say, well, I don't let them run around because they will start coughing or they'll start wheezing. If they get hot, they start coughing and wheezing. that's not what you should do. The point is that children should be able to live regular, productive lives, and of course that depends on how bad their asthma is, and you shouldn't have to make them sit down. If they're having to sit down and not play because they have asthma, then we need to fix their asthma. We don't need to make them stop playing. So play is very important for children, older children and adolescents. Sports can be very important, and again, these are all times that we stress our lungs. We'll talk about later about kids growing out of asthma, and I really do think that's really something we should not really talk about. We should really think about controlling the asthma that we have symptoms for. But there's a lot of evidence to show that that chronic inflammation in the lung persists, potentially even lifetime. Now, that's not to say that there aren't children who grow out of asthma. I have seen that, but that chronic inflammatory cycle. What if you, as a young person, were told that you can't exercise because all you do is cough and wheeze? Well, then you don't exercise, you don't play sports, you don't participate in PE. Then your pastime is playing video games. You're not stressing your lungs. It doesn't mean you don't have asthma. It just means that you don't flare because you're not stressing your lungs. So let's move on from talking about growing out of asthma and talking about controlling symptoms to let kids have normal lives. And we've already talked about triggers. So we think about allergens. I've seen children go to a campfire and maybe haven't had symptoms in a long time, and they go to a bonfire and they get exposed to smoke and they start wheezing and they start coughing. Maybe they go into a home of, maybe they live with non-smokers and they go into a home that's a smoker and they immediately start coughing and wheezing. And then we've already talked about the role that these common everyday respiratory viruses, RSV is one, but there's also flu, there's echovirus, there's rhinovirus, there's coronavirus. There's so many different respiratory infections that we see, adenovirus, that affect children that we need to be thinking about when we think about these triggers. So what do we do about asthma? So, as you may know, inflammatory diseases are treated with anti-inflammatory medications, and one of the mainstays of anti-inflammatory medications are steroids. Steroids work really well, and they are the therapy for children with asthma. In a minute, we'll start looking at some of the treatment protocols for children with asthma, and at the top of all of these charts, what you'll see is the word ICS, or the initials ICS. That's inhaled corticosteroid. Inhaled corticosteroids are great because they go to where the inflammation is, which is in the lungs, and they minimally go to other places outside the lungs. The problem with oral steroids is that they go everywhere from your toes to your hair follicles, but they also go to your lungs, and they can be life-saving when children have severe flare-ups. But we do not want children to be exposed to the doses that you have to get when you get oral steroids. The goal is that they stay on their controller medication, which is the steroid in most cases, and it can be others, and we'll talk about those. Now, when they get into trouble, we use what are called beta agonists, and the reason they're called that is there's a receptor that's on the smooth muscle. It's called the beta receptor. It's also on the heart muscle, where you give them a medication, and most people know this as the medicine albuterol, but it's also known by several brand names, and we'll go through that. But albuterol relaxes the smooth muscles in the airway and helps you breathe better. So many times, what will happen is someone will be exposed to a trigger. Their asthma will flare. They get their albuterol. They feel better. It's a short-acting medication. It wears off, and then they go back and their symptoms return. And the goal is that you make sure that they're controlled on their steroid, and potentially you have to either up the dose or give them oral steroids to make sure that they don't get worse and end up potentially in the hospital or on oxygen. So you think about steroids and beta agonists. Those are the mainstays of therapy. How do we know people are being controlled? We have to ask. We have to ask them their symptoms. Do they cough at night? Do they cough when they run around? Do they wheeze? Have they been to their healthcare provider and been treated? Have they been to the emergency department? Have they gone to the ICU? Have they been admitted to the hospital with an asthma flare-up? These are the ways we know. And many times it's the easy questions, the simple questions that can lead us into knowing whether or not someone is controlled or not controlled. And we'll get into the definition of control. But the main thing is that we see them regularly, we evaluate their treatments, and we modify the treatments based on where their symptoms are. And we take that into the consideration of what time of year it is, what are their particular triggers, and that's another thing you should ask about is triggers. What is it that makes your child's asthma trigger? And remember, those triggers may be all around them, maybe even in the home. There could be animal dander, it could be dust mites, it could be cockroach, it could be mold. All of these things can trigger those. So you see children who have severe symptoms at home, but then they go somewhere else and they do better. That might be consistent with something in their home. So thinking about those things, and then things that they can, and we'll talk about some of that later about allergen reduction. And then finally, we talk about an asthma action plan. And an asthma action plan is simply in most cases, a piece of paper where you write down what to do when things go wrong. So when things are right, you'll see an example in a minute. When things are right, you're in the green. You take your regular medicine, you do your regular therapy, and you don't change it until you're told to by your healthcare provider. You fill your medication, you do it as regularly as possible, knowing that that's going to keep you under control. Once you start flaring, and it may be no fault of theirs that they flare because they were exposed to a very severe virus, and so you have to know what to do when symptoms flare. And then if symptoms get really bad, we talk about green, yellow, red, kind of the stoplight approach. Green is every day, yellow you layer on your next layer, and then red is when you're in trouble and you need to seek medical care. People need to know that. So we talked about inhaled corticosteroids. Inhaled corticosteroids are delivered in different ways, primarily through what are called metered dose inhalers or dry powder inhalers or the nebulizer. Children may be on one or potentially other of these medications. There are other combination medications, and we'll get to those in a minute. But I wanted to give you an idea of some of the brand names and then some of the generic names for some of the commonly prescribed inhaled corticosteroids. And you can see these on the screen here. These can be delivered in different ways. These medications have different delivery systems. Even among the different medications themselves, they may have different ways of being administered. For example, Pulmicort or budesonide can be delivered both as a nebulized solution but also as a dry powder inhaler. Flovent in the past has been able to be delivered as a meter dose inhaler, an MDI, or a dry powder inhaler. So these are very common, but they're all steroids. Steroids control inflammation. That's why you take them. These are low dose, so that's important because we want the steroid to go to the area of activity, which is the lung. We want to make sure that steroid side effects are minimized, and we'll talk about those. But again, these are low dose, and they're given daily to make sure that they control on a daily basis. So then we talked about rescue medications. These are the albuterol medicines. So albuterol is the chemical, and then there are other brand names. At the moment, there are no non-branded forms of albuterol delivered in a metered dose inhaler, which people call commonly a puffer. All of these are branded medications. And that's important because in some cases, branded medications may count against a certain limit. They can also be expensive, but they changed the formulation several years ago, and there are no generic albuterol inhalers. All of them go by one of these names. There is, however, generic albuterol suspension for nebulization, which is a liquid that goes into a machine, although there have been some shortages of that recently, but we'll get to that in a second. So again, these beta agonists, these albuterol medicines, these are short-acting. You'll see SABA, that's short-acting beta agonist. The main side effect of these beta agonists is a fast heart rate and shaking. And that's because of the activity of the beta receptor that we talked about is on the heart, but also on the lungs. So these children will very commonly have very fast heart rates after they have a treatment and can be very shaky and jittery for a little while. But because they're young, because their hearts are healthy, they do very well with that. Now, there's some other medications that you'll see in the guidelines, and I wanted to briefly introduce you to these because you may see these. There are what are called long-acting beta agonists. So as opposed to short-acting beta agonist, albuterol, these are medications that last longer. That's why they're called long-acting. They're still beta agonists. They're still like albuterol, but they're different chemicals. So they last longer, but they're not used by themselves. These medications should always be used in combination with an inhaled corticosteroid. In fact, using them by themselves has been an independent risk factor for death from asthma. So these are never prescribed by themselves. They're prescribed in coordination with in combination with other medicines, specifically inhaled corticosteroids. There's also long-acting muscarinic antagonists. These are relatively new. There is only one, and these are also not used. These are also used in combination. And you'll see in the guidelines that the LAMA medicines may be prescribed along with an ICS and an LABA in a combination medicine format. So that's something you may also see. We think about the medicines Accolate or Zerolucast and Montelukast, and you can see these medications, these are called a leukotriene receptor antagonists. Many people may have heard of the medicine Singulair. It's not a preferred first-line medicine for asthma. It can be used as an adjunctive therapy, meaning it's added on, but it's usually added on with inhaled corticosteroids. And it's particularly helpful in people who have allergic triggered asthma because it has combination pathways with both allergies and asthma. Nasal allergies, for example, are treated with low-dose intranasal steroids, much like low-dose inhaled corticosteroids, but you can also use other medications like, think about antihistamines, for example. These are a little bit different, but you'll see these in the guidelines as well. They're usually called LTRAs, if you see them abbreviated LTRA. Theophylline and cromolyn, these are medications that aren't used very much anymore. These are medicines that were used some time ago. They are still in the guidelines, and then you may see them prescribed in some children who have very, very severe asthma or difficult to control asthma, or potentially have side effects on other treatments that make them unable to take them. We talked about these ICS plus LABA, and you'll see some of these, you'll see the brand names here. These are very commonly prescribed. The nice thing about these long-acting beta agonists is that you get your inhaled corticosteroid, but you also get this long-acting medicine that potentially keeps you controlled throughout the day so that you have less symptoms while using even maybe smaller doses of steroids. And then you can see there are also these newer combination corticosteroids plus the long-acting albuterol formulations plus these newer LAMAs that we talked about. And then finally, we think about oral steroids, and that's really the last option. For most people in a healthcare setting, oral steroids are the highest level of therapy that they can get without going to a hospital. Oral steroids are used when children are flared, especially if they are in some respiratory distress, but they are normally under good control. They have a flare. They're not being able to be controlled with their albuterol. So you give oral steroids for a brief period to sort of calm down the inflammation. And then they go back to their regular therapy. Usually you give no more than 3 to 5 days of these medicines. Once you go to the hospital, there's many other medicines that can be used, but that's beyond the scope of this talk. But think of oral steroids as sort of the mainstay. That's the one you'll see the children on if they maybe had just gotten back from their healthcare provider's office or the ER, or even potentially had been an inpatient and been sent home. They'll usually be on steroids. So there are a few other, the one that I wanted to mention briefly is the asthma biologics. This is something that you will see very, very rarely. I can tell you in 14 years of private practice, I had only one child who was ever on an asthma biologic. These are newer medications. They have been around for some time, but they are newer. They target specific receptors in the inflammatory pathways that are specific to asthma. They can be life-saving in children who have just unbelievably severe asthma, but they are very infrequently. They're extremely expensive. They're hard. They're given as through a needle. It's not something they can do just in the NDI. And if you see these children who are on these unusual medicines or very severe or even on biologics, these almost always are followed by what's called a pulmonologist. So a pulmonologist is a specialist who focuses on diseases of the lung. There is adult pulmonologists, there are children pulmonologists. Pulmonologists in children, they typically focus on children who have lung disease, maybe due to prematurity, but also children who have asthma and other diseases of the lungs, cystic fibrosis, for example. In adult pulmonology, they may deal with asthma, but they deal a lot with what's called COPD, which is asthma-like and is treated very similar to asthma. Generally, children don't have COPD. although it's possible for children to have sort of a crossover between children, but that's not important. The most important thing is that you know that these children are very commonly seen by pulmonology, and maybe even seen primarily by pulmonology. There may be times when, as a practitioner in the community, that you send a child to the pulmonologist to have a workup because you're having trouble getting their symptoms under control. They see a pulmonologist, and then they're sent back to sort of be managed by their local person. And that's very common as well. So children may have seen a pulmonologist, but may not see a pulmonologist regularly. They just see their local provider. So let's talk a little bit about these medications and how they're delivered. So you see on the end there in the red, that is the typical metered dose inhaler, or people call it an MDI. People also call it a puffer because it puffs medicine. What's important about these puffers is that they spray medicine out very fast. They have a propellant in the bottle. Usually these medicines have a certain number of doses, and many of them will even have a dose counter on them. So I think it's important that you look at the dose counter, make sure there's enough medicine in there. But the medicine comes out very fast. Honestly, too fast for an adult to coordinate a breath where they get the albuterol into their lungs. So we think about albuterol, but we also think about the inhaled corticosteroids that are delivered through this MDI. So with an MDI, the best, for both adults and children, the best practice is to use what's called a valved holding chamber, or people call it a spacer. And this is an example, a picture of what one of those spacers looks like. A spacer or a valved holding chamber essentially slows the medicine down so that you can get the medicine into your lungs. When we think about metered dose inhalers, they're wet medicines. They're suspended in a mist. So with these medicines, they're very heavy, and they take a slow breath to get them down into the lungs, a very good deep breath, and then you want it to deposit into the lungs before you breathe out. Now these can be used all the way from infants to adults. There are ones, and you'll see in the video that we show in a minute, there are ones that have a mask that can be sized differently for different children. So it's important when you are evaluating a child who has a metered dose inhaler with a valved holding chamber or spacer, that the spacer is appropriate for them. If they're young enough, it fits their face. Children, the one that's on the screen now has a mouthpiece, and younger children cannot do a mouthpiece because they can't understand breathing in and out in following directions. So these should only be used in older children who can follow directions. And what that means is that they can breathe in on command, hold their breath, and then breathe out slowly. All by coordinating this. So breathing out, taking the medicine in, holding, breathing out. That takes a little bit more coordination. So these are older kids. For the younger kids, you can simply place the mask over their mouth, and you can just spray the medicine and then watch 6 breaths in and out, and you know that they've gotten the majority of the medicine. And so that's very important. You should separate each medicine dose by about 30 seconds. So if you're giving two sprays or 2 puffs, you want to do 1 puff, you do your 6 breaths or your in and out, wait 30 seconds and deliver your second. So the next is a video that was published by a large healthcare organization showing the meter dose and spacer technique.
Today I'm going to show you how to use this chamber, okay? You ever seen one of these in your house? Mm-hmm. Yeah, good. All right, this is an aero chamber. It allows us to puff the medication, get a cloud of the medicine here, and then you get to breathe in and out and get the medicine into your lungs. Where do you suppose this goes? Nose and mouth, right? Okay, good. Let's try that. Let's see how it fits. I want you to breathe 6 times for me, in and out. We're going to check that you can get a good seal, and the flaps move. So the flap is right here. Good. There's 1, 2. Gentle breathing is fine. 3, 4, 5. 1 more. Perfect. Relax. Was that hard? No. All righty. Good. Thank you very much. Some other details about this chamber are it has a rubber fitting in the back. This rubber fitting allows fit of the inhaler. Occasionally an inhaler is round. They'll still fit in this device. When you clean this device, you can remove the rubber piece and use a soft cloth and soapy water to rinse and clean the inside, and then just rinse and air dry. They have a Teflon coating to help the medication not stick to the chamber, but if the chamber is being used regularly, like twice daily on a routine basis, then about every week you need to be cleaning your chamber. You can use a soft cloth to clean the mask itself. Some children get a reaction from the actual plastic. That's very rare, but if you see any kind of redness or something happening around the skin of the nose and mouth, you can just wash off their skin after you give your doses of the medication.
So this video has a lot of good points. In the beginning, she mentioned the brand Aero Chamber. That is a brand. There are many different types of valve holding chambers. She mentioned how to clean the chamber. That's important. Now, all of this should be done at the prescriber's office. Every person should be taught how to use this when they're receiving the medication. And this is very commonly done in pediatricians' offices. I know I did this myself with dummy devices, where we would show people how to do it without them actually touching the device. We'd give them a little, and then we'd also give them handouts. And so there are handouts. She talked about the coating on the inside of the device that allows the medicine to not stick, so that there is a time period where you can spray the medicine and then put the child's mouth on there, because it is valved, so that the medicine is not going in unless you breathe in. And she talked about the flap, and then finally talked about cleaning the device, which is important. And all the devices can be cleaned. These devices can be refilled on a relatively regular basis. So it's important to know that insurance companies will fill these. They will fill potentially several in a year, depending on where a child is. And it may be that a child needs multiple of these to have in different places. So say, for example, if they are playing sports and they're responsible for delivering their own medication as older children, they may need one in their bag. Or maybe they live in multiple different households. They need one for every household. That is possible to do. So do remember, MDIs go with, or meter dose inhalers, puffers, they go with spacers or valve holding chambers. And that's very, very important. And remember, the age of the child is what is the factor. And it's also the development of the child. It's not necessarily age. There are some children who are, I've seen children who as young as 4, 5, and 6 who can follow the directions on an MDI. And I've seen some children who as old as 9 or 10 or 11 could not follow the directions on an MDI. So it really just depends, but they need to be used this way. If you don't use the spacer, most of the medicine ends up in your mouth, which ends up in your throat, which ends up in your stomach, which does absolutely nothing for your lungs other than just give you a little steroid into your body. So there is steroid that goes into your body through the meter dose inhaler when it goes into your lungs, but that is very minimal, and we'll talk about that toward the end. The next type of medication that we talk about is a dry powder inhaler. And this is different than the meter dose inhaler, because this is a dry powder. This device is called a discaler, and it is a device that is used by one particular manufacturer. But the point is not what it looks like. The point is what's going on inside. So inside this device is a disc that has small bubbles of a very, very fine powder that are in sort of this little capsule, so to speak. So at some point, regardless of what this thing looks like, you have to break the capsule. With this, it's a lever. With another one, it might be a twist. But there's some sort of a pop, a click that opens that medicine up. So now it's to be inhaled into the lungs. And so this medicine has to be inhaled quickly into the lungs. It has to settle because it's a very, very fine powder, so people need to be able to hold their breath and breathe out slowly so that they don't exhale all the powder they just inhaled. So you'll see a demonstration of this in the next video. But remember, these medications should only be used in children who can follow the directions. If they can't follow directions, they're not getting the medicine. They will not get better. The medicine is very, very, it's very particular to each child and to the developmental stage. So let's watch this next video.
Medicine can get deep into the lungs through a dry powdered inhaler, or DPI for short. Here's how older kids and teens can use a DPI. How are DPIs different from metered dose inhalers? Unlike other inhalers, which deliver a puff of medicine, these inhalers hold the medicine as a dry powder. Since the medicine sits inside as a powder, you have to breathe in fast and deep to get the medicine into the lungs. Place thumb on lever and push your thumb away from you as far as it will go until you hear a click. Turn your head to the side and breathe out. Do not breathe into the inhaler. Close your mouth tightly around the mouthpiece while holding the device flat. Breathe in fast and deep through the mouthpiece. Hold it like a hamburger, suck like a milkshake. After you breathe the medicine in, hold your breath for a count of 10. Then slowly breathe out. Close the device when you're finished so it will be ready for your next dose. You may not feel or taste the medicine. Rinse your mouth out with water or brush your teeth after using dry powdered inhalers. Wipe the mouthpiece with a dry cloth after each use. Always keep the dry powdered inhaler dry and never take it apart. Remember, if you have questions, call your doctor's office, asthma care team, or pharmacy.
So one important thing that she mentioned was about rinsing their mouth after the medication. The reason she said that is because if you are on a steroid and it gets into your mouth, it can set you up to have thrush because steroids suppress the immune system. That's how they work. That's why they're given to people with cancer, for example. So they suppress the immune system, and when your immune system is suppressed, other things can grow, and in this case, it's candida or thrush. So I think it's important anytime is on any sort of inhaled corticosteroid that you try to get them to either rinse their mouth out or brush their teeth after they use the medicine. It's actually a good way to help them remember how to and when to take their medicine is to do it when they brush their teeth. Since many of these medicines are dosed twice a day, even if they're dosed once a day, just put it right next to the toothbrush. I've had another person tell me one time that they used a rubber band and wrapped the rubber band around the inhaler in the toothbrush so that they knew to do it every time. So again, different techniques, different types of medicine. Make sure that you're paying attention to this, because if you see a child and you notice that they can't do it, then they may need to be on a different form. The last one we'll talk about is about nebulizers. So nebulizer, what this is this is a small air compressor that sends a pulse of air over and over again through a tube, and it aerosolizes or causes a mist out of a liquid that goes into a mouthpiece and into the child's lungs. Nebulizers are good for very, very young children. But remember, young children don't have to have nebulizers. There are downsides. Number one, these machines are expensive. They can only be refilled infrequently by insurance companies. They are typically not allowed for children older than about 9 years of age, simply because these children should be old enough to be able to use a dry powder inhaler or an MDI. The other thing too is that the tubing goes bad, and so you have to make sure the tubing is replaced on a regular basis. These medications make a lot of noise and they make a lot of mist, and it looks like there's a lot of medicine, but the fraction of medicine that's in the actual suspension that you're pouring into the device is minuscule. Most of what you're inhaling is actually salt water, just sterile salt water. So these medicines they only make a tiny fraction. So a lot of what you're seeing is that, but they can be helpful in some cases. It does require a power source. That's another downside of these medicines. They can be difficult to take places, or maybe not as portable as you would like. That could lead into what happens if you lose power or you are in a disaster situation. So there are downsides to these devices, although you will see them. There is medication, an inhaled corticosteroid, the budesonide specifically, that can be delivered this way, and you'll see young children on those. It's important that children, when they're getting these treatments, are relatively calm, and that's true for any of the treatments. The faster and more ragged a child breathes, or if they're crying, they're not getting the medicine into their lungs as well as if they're calm. So doing it when they're calm is definitely important. So you'll see that as well. And sometimes these medicines come with mouthpieces, but younger children have problems with that. Many times also that they'll distribute these with a small face mask that you can place over the child's mouth and nose, and you can deliver it that way as well. Okay, so let's move into, we'll talk about therapy. I don't think it's important for you to understand exactly how a child's treatment goes, but what I do think it's important is to know the general theory of treating asthma. You treat the asthma so that the child lives, again, we're going back to they live healthy, productive lives. We use the minimum amount of medication that we can to avoid any side effects so that they can play and have fun and be children. That's what we do. If you look at this chart, there are 3 charts, and this is called the stepwise approach to asthma therapy. So you have different steps of therapy, and each step represents a higher level of therapy. And this is broken down by 3 different age groups, 0 to 4, 5 to 11, and 12 and up. And you can see, we say 0 to 4 because, again, it's not that you can't diagnose asthma less than 2. Children can be diagnosed with asthma very young. So this is what you do. You start them on a step, you assess their control, and then you decide whether or not, if they're not controlled, they move maybe up a step or maybe 2. If they are controlled, you move them you after a period of time, usually after they've gone through a period where they maybe for example, say they always get sick in the fall and the spring. So you wouldn't want to decrease right before those times. But say they've gone through a time and they've been stable, you can walk down their medicine. You'll see in step one is called intermittent asthma. That means it's not chronic asthma, it's just intermittent asthma. It just flares up occasionally. And that's treated with step 1. Generally, it's just treated with albuterol as needed. But every other step is where we talk about persistent asthma. All of these conditions are chronic, but this asthma are described as persistent. And so you can see those steps there in front of you. Control is defined as using albuterol less than twice a week during the day or less than twice a month at night. Nighttime symptoms are more sensitive for uncontrolled asthma than daytime symptoms. The other thing you look into is whether or not they've had to use oral steroids in the past, say for example 6 months, or have had any hospital admissions or anything like that. So you just, again, you move up or down on these steps to control the asthma, and you'll see across all of the steps, the very first medicine is ICS. It's inhaled corticosteroids, but then there are others as well, and you can see the preferred and then the alternatives that are below. So that's how asthma is done. And if you look at, this is the first one, let's look at number 2. Looks very much the same. Now the medicines are different. For these older kids, because they do have different indications, and these have changed over the last few years. Pulmonologists were very quick to use some of the dual medicines, the ICS plus the long-acting beta agonists, before they were approved, and they have since been approved because they've shown such good promise as being good medicines for children. So these medicines have worked their ways down into younger children. So you can see, but the stepwise therapy is the same. It's the same thing. We step up and step down based on the symptoms. And then the final, and that also goes for those 12 and up. Again, medicines can be different, but it's still the inhaled corticosteroids. It's still that step up and down. And we're just trying to make sure that they live healthy, normal lives with minimal medication interactions. So how do we monitor children with asthma? We've already talked about it. A lot of it is asking questions. Do they cough? Do they wheeze? Can they run? Can they play? Do they go to the doctor? Every time they have a cold, do they end up on a steroid? You'll even see adults that maybe as children had asthma, but every time they get a severe cold or maybe their allergies flare, they end up in a doctor's office and they receive an inhaler and steroids. You probably have some degree of ongoing asthma that's just not as active as it was earlier. So children can, again, this is a spectrum. So we ask questions, and we have standardized screening tools like the asthma control test. And what these do is essentially they just take the questions and they standardize them, meaning that you ask the same questions at the same time for the kids that are appropriate for the test. And these usually are 12 and up versus 11 and under. And then it gives you an idea of how well they're controlled based on the questions you ask, and then you can report that back to their prescriber, for example. And prescribers can also use these in their offices to get an idea of how well a child may be controlled. Spirometry is another way that we both diagnose and monitor symptoms in children. Spirometry is a very complicated test. It requires expensive equipment. It requires a person to know how to do the test and how to coach the test. And it requires that the child or adult, depending, be able to follow the directions. So this, again, is not something that's done in very youngest children. There are other tests that can be done, but children need to be able to follow directions. They need to be able to know you breathe out, all your breath out, and then you do it again, and you do it again. But the nice thing about spirometry is that it gives you actual numbers. You can see on a graph actual numbers of what their lungs are doing, and that can be very helpful in knowing what's going on, especially in older kids or adolescents. And then sometimes people use peak flow meters. These have not been used in some time very widely. You'll see an example of one on the screen. These are just simply devices that measure how much breath you can blow out at a time. And so they give these out potentially to children, and they say, okay, well, here's your green zone, you're breathing well. If you can't breathe out and you do this and it goes down into the other colors, you know that you're not breathing well, and that gives you an idea. These used to be used a lot more. We don't see them much anymore, but I wanted to at least give you an idea of what they look like. This is an example of an asthma action plan published by the National Heart, Lung, and Blood Institute, which is the group of the government that is responsible for the asthma guidelines for adults and children. And we'll have references at the end. But again, this is that stoplight approach, the green, yellow, red. Every child, and I want to reiterate, every child should have this in their home. And it should be prominently displayed so that everyone sees it. The green is your everyday. That's your controller. These children are going to have persistent asthma for the most part. So the green is the controller. That's their everyday medicine. They take it every day, sick or well, regardless. Yellow is what happens when they don't do well, and their prescriber fills that in, and that tells them exactly what to do. And then when they get into trouble, they know what to do. They know where to give the medicine and when to call and where to go, potentially, depending on who's open. That could be an emergency room or anything like that. So asthma action plan, extremely important. So why do we worry about steroids? All medicines have side effects. Medicines they just have side effects, and steroids are not immune to that. They can cause growth problems. They can cause bone problems and eye problems. People have seen that in adults who take chronic steroids for they've had a transplant or any other condition where they take chronic steroids, arthritis, for example. You can have problems. The goal is, again, minimal medicine, maximum effect. But I wanted to give you an idea of why it's so important that children are controlled on these low-dose inhaled corticosteroids. So I gave an example here of a child who, for example, has a flare-up. And say they're about 55 pounds. In pediatrics, everything is in kilograms. So we would potentially dose this child with about 50 milligrams once daily for 5 days for a flare-up. That's a typical dosing, 1 to 2 milligrams per kilogram per day for 5 days. That's about 250 milligrams that child would get over a 5-day period. Let's say, for example, that this child is maintained on a twice daily dose of the inhaled corticosteroid fluticasone on a twice daily basis. So these are 2 puffs twice a day. That would end up being about 5.28 milligrams per month of medicine. So a very tiny fraction of what you would get in even one flare-up. Pulmonologists that I talked to said that you can expect children absorb about 33% of the medicine that they get. So figuring that, we can say the child gets potentially about a little over 1.5 milligrams per month, and over a course of a year would only get about 20 milligrams. So it's just a tiny fraction of what you would get even in one flare-up. So if they flare twice in a year, they've potentially gotten 500 milligrams of steroids. So just remember that. It's very important. I also did the same calculation for if a child was on budesonide, say in a nebulizer. Same thing. The medicine it's still just a tiny fraction of what you would get in one flare. So these medicines, and the goal is that as they get older, maybe they're not exposed to as many viruses, they don't get sick as often, they don't wheeze as much. We step them down. We use our stepwise therapy to get them on less medicine. We add other medicines in as the situation dictates to make sure that we use as little steroid as possible to treat their symptoms. And that's why when you get into the older children, into the very high doses and the more chronic steroids, that's why they use those adjunctive medicines like the biologics, because they just can't handle that much steroid over time. So I think that's an important thing to realize, and parents don't realize that often. So we talked about, do kids grow out of asthma? Possibly. I don't think about that. When I treat asthma, I think about children having asthma, and it's long term. Maybe their situations change, maybe they don't do as much, but the inflammation is still there. It's still very low lying, and it potentially could cause long term effects in their lungs, even in the absence of smoking or anything else. So I think it's important. So what do? We encourage people to take their medicines as prescribed. They don't stop their medicines. People, and we all do this, we stop taking our medicines and we feel better. But that's very important for children not to do that. They need to take their medicine, they need to get into the routine, they need to work with their prescriber to get as simple a regimen as possible, potentially going maybe down to once a day instead of twice a day if they can handle it. We just need to make sure that we're supporting our kids, and that's why it's so important that we continue these medicines on a regular basis. So to wrap up, I hope this gives you a little bit of an understanding about asthma. I wanted to show some resources. If you are interested in this, there is a over 300-page document that you can read from the NHLBI. And all you have to do is type in NHLBI, or you can type in asthma management guidelines. It was most updated in 2021, so it is recent. And all of the graphs, the asthma action plan, everything you've seen today is in that document, in addition to extensive information about allergen reduction. And we talked about how important that might be in certain situations. And we didn't touch on that much, but potentially keeping animals out of the child's room, making sure they don't sleep in the bed with the child. If they have a lot of pillows and carpet in their room, potentially taking that out for dust mite purposes. Potentially even getting them tested for other allergens by an allergist may be important. All of these things can be helpful. So make sure you consider that as well when you're talking to your families, that they may have seen both. And of course, the CDC, the American Lung Association, we used a video from the Mayo Clinic. We also saw a video from Nationwide Children's. Plenty of information out there. We're going to give you resources to help you with this as well, to make sure you know the questions to ask, you know how to provide documentation, you know how to identify the medicines, and then hopefully we can have other resources as well. So I hope that this has been helpful for you. Again, my name is Wes Stubblefield. I'm available anytime. I'm the only Stubblefield in the directory, so you can email me, you can call me. I will always be responsive for you to have these things, and we will be working with our RPM colleagues to make sure that we get this program implemented effectively, safely, and see if we can make the difference in the lives of children and parents. Thanks so much.